All right, we're recording. She's giving, I'm lip reading at the same time as looking at my slides. Fantastic. Okay, so welcome everybody. My name is Elizabeth Reinald, and today we're starting the first in a series of lectures about specific to working in the personal care home setting during the COVID-19 pandemic. Before we get started, just knowing your audience, could you please, if you're using Menti.com, could you answer your experience with the clinical frailty scale? And I should have a copyright logo on there, but Mentimeter didn't allow me to do that. So have you heard of it? Have you heard of it but never used it? You tried it, you didn't like it? No love it, use it all the time yet. So hopefully by the end, we'll have you convinced that you love it. We got one person who I'm going to have to improve the sales pitch. Thank you for your honesty. So today the things that we're trying to achieve is more specifics about the clinical frailty scale and some important points about using the clinical frailty scale. And then we're through some cases going to try to gain some confidence using the clinical frailty scale, particularly compared to age when considering treatment options for personal care home residents during the COVID-19 pandemic. So the clinical frailty scale is one tool, and here we have the link to the Dalhousie University information about the clinical frailty scale. I'll talk more about the scale, but as far as these slides, there are a lot of live links, and Jocelyn's going to send out an email with a PDF of the PowerPoints that'll have live links to all of the resources after the presentation. So usually we put our references at the end of a presentation, but I wanted to highlight something that's recently been published by the Canadian Geriatric Society COVID-19 Working Group. Early on in the pandemic, when acute care ICUs were in crisis in some communities, there was information coming out that some countries were triaging scarce resources based on age, and many people working in geriatrics are very, very against age being used as a cutoff. When there are ethical dilemmas, there sometimes needs to be resource rationing, but age itself is not a good marker of who benefits from treatment. So the Canadian Geriatric Society published their thoughts about a better way of making tough decisions, and it's published online. And they highlighted that frailty is if you have to make tough decisions, either in clinical scenarios or about resource rationing for the greater good, that frailty would be a better predictor of who may not benefit from intensive treatment rather than age alone. And some of the background evidence and references are included in this paper. So overall, starting with the topic of frailty is important for the personal care home, people who work with personal care home residents, because all of our residents are frail. Otherwise, they wouldn't need to be in a personal care home. Now I'm noticing that my slides are a little cut off, so I think I'm going to try to hide these pictures of people just so that, well, that made it worse. Thumbnail video. Okay, there we go. So don't give me any more hand signals because I've hidden the video. So frailty is a way of describing people who are at increased risk of adverse events, morbidity, and mortality. This is overall. This is frailty as a concept predicts this in the community setting during usual care, but it also has evidence for predicting vulnerability to adverse events in critical care units. And further to this, there is validation that frailty status can be determined in a few different methods. So not to go into too much detail, but there are two main different ways of assessing frailty. One is with an accumulated deficits, or overall how much is your frailty affecting your functional independence, which is the clinical frailty scale method of assessing frailty. And the other is more of a measured thing, looking at gait speed, grip strength, and a number of other measurable things as a way of estimating or describing people's frailty. But I'm going to focus on the accumulated deficits, or the clinical frailty scale method of assessing frailty, not just because it's also something that was developed in Canada, but it's getting international attention. And one of the earliest groups to incorporate that into their COVID response was the National Institute for Health and Care Excellence, so NICE. And they were very early in putting together a rapid guideline for clinical care in adults. The reference or the website is there, and they had it in a nice algorithm here. And what I'll highlight for you is in the UK with the National Health Service, the need to assess an older adult's frailty was right at the top of the algorithm, and it informed the rest of their care. And as some of you may have heard me say in other settings, this is an approach for older adults that works throughout our care. So rather than saying the age of somebody and forming your approach, starting with an assessment of overall how frail or how vulnerable they are, then helps you with the remainder of your approach to their care. And this holds true in some of the COVID-19 cares. This isn't really a talk about critical care. In fact, next week is going to go into a little bit more detail about the intensive care or the lack of benefit for personal care home residents from the options of critical care. But what I do want to touch on is that there is validation of the clinical frailty scale in predicting how people do in critical care settings pre-COVID. So there are studies right now trying to validate the clinical frailty scale as predicting how people are going to do specific to COVID-19, but it has been published in critical care. And this Bagshaw et al. Is sort of the most referenced paper for critical care using the clinical frailty scale. And there is a cutoff. So the yellow line doesn't show up well. I don't know if you can see my cursor, but the very robust, regardless of age, older adults with a clinical frailty scale of 1 to 3 have outcomes that are similar or not much worse than younger people with the same vigor. But when people become frail, so when they are the green line, mildly frail or frailer, their outcomes are decidedly worse. 4, which is vulnerable, is sort of in the middle. But if you want to predict people's 1 year or even very quickly, the lines separate, even at the ICU mortality, their frailty predicts how they are going to do. So this is the clinical frailty scale. It is operationalized in this pictogram, but I want to mention that it's not, you don't sort of look at a person from the end of the bed and then decide how frail they are, whether or not they match the picture. As with all things, the devil is in the detail, and the way to use the clinical frailty scale is by asking some questions about how independent the person is, and then basing your opinion about their clinical frailty scale score on how much help they're requiring. So I'm just going to run through this for those of you who have never used the clinical frailty scale first. In the personal care home setting, there is nobody who is very fit. These people are very fit regardless of their age. They are exercising vigorously and able to do everything independently at their baseline. So they are the fittest for their age. Two are people who are well. They don't have any active disease symptoms. They may have underlying comorbidities, but they don't have any active symptoms that are causing them any limitations, and they are active. So they're not sedentary or, quotes, slowed up. People who are a clinical frailty scale score of 3 are not frail. They're managing well. They have medical problems that, when they exacerbate, can cause some limitations, but they're well controlled in the recent past. But they're starting to get a bit sedentary. They're maybe not as active, and this may be because something in their life is becoming a little bit more complex, but they're independent. People who are vulnerable still are not considered frail. They are a clinical frailty scale of 4, and they have some symptoms that limit activity. So not unable to do anything or requiring assistance, but maybe they're having to use other strategies. Maybe they have to take breaks because of underlying symptoms. Maybe they describe themselves as slowed up. They may or may not use a gait aid. The cutoff is between a 4 and a 5. So people who are a clinical frailty scale of 5 are mildly frail. That's the line in the sand. 4 and less, you are not frail. 5 and more, you are frail. But it's not binary. This is sort of gradated, and people who are further along the scale are frailer than mildly frail. So people who are mildly frail are having to get some assistance with some of their household chores and their higher order independent activities of daily living. So I've heard this described as the things you need to be able to do to survive when you move out of your parents' home. So this includes the IADLs, which some people may be familiar with, including finances, transportation, all of the housework, all of the organizing, a number of medications. Now, some people may not be on a lot of medications, in which case you can't really use this to assess their whether or not they're mildly frail. But overall, for any reason, so whether it's mobility impairment, whether it's endurance from cardiac symptoms, whether it's cognitive symptoms making them less motivated or unable to remember to do things, any reason why you're starting to need some help with your IADLs means you're mildly frail. 6 is moderately frail, and this is when people start needing some cueing or assistance with their personal hygiene. So this may be often at this point, you're needing help with more of your household chores or IADLs, and you're starting to need any amount either for mobility and assist in and out of the tub because of falls risk, or you've got some range of motion problems, so you can't get your socks or your compression stockings on. So for whatever reason, you're starting to need some help with your personal hygiene, bathing, dressing, grooming, and then as people become frailer, they move to severely frail, which is a frailty scale of 7. I'll just mention there, if you are familiar with old versions, when this was originally validated in 2005, 2008, there was a 7-item frailty scale, and they had to make some adjustments that I'll explain. But this version of the scale, which is currently being encouraged to be used, it goes up to 9. So at a clinical frailty scale of 7, people are needing help with all of their ADLs, all of their personal care, they're not unstable. They're not, we're not necessarily expecting them to die soon, but we wouldn't be surprised if in the next 6 months they were actively dying or pass away. So frailer than that is in the end of life phase, bedridden, perhaps not awake much of the time. We are expecting them to die. And when they adjusted to the 9-point clinical frailty scale, they realized they needed to add a 9, which is terminally ill. So there are settings in which somebody is very independent, but they have a diagnosis that is expected to kill them within the next 6 months. That trumps any of the rest of their frailty. So if they have a terminal illness that we expect will kill them, even if they are currently functionally independent, then they are a clinical frailty scale of 9, because we are expecting them to die from something that is a bit more predictable. For the personal care home setting, these people, the moderately frail 6 and the severely frail 7 and the 8s are very common, but there are some mildly frail people living in personal care homes for various reasons. So the 5 to the 8s would be the 4 of the scale rankings that we would be thinking about most commonly in the personal care home setting. In the community, in acute care, in emerge, you really need to be thinking, although they may be rare, you need to be thinking about all the way from 1 to 9. And my slide, come on. Oh, there it is. So a couple of points have become very clear as the National Health Service in the UK added the clinical frailty scale to their algorithm, is that they found they needed to emphasize a few things. One, this scale is not validated for people who are younger than 65 years of age or people with long-term disabilities that are stable. So this is something to keep in mind, that you can use the approach. If somebody is younger than 65 and becoming more dependent gradually because of accumulating deficits, that may very well be relevant to their clinical decision making, but the tool itself has not been validated in that particular population. And very important is you're not making this judgment based on seeing them acutely ill, God forbid with COVID-19. You're wanting to base their underlying frailty based on 2 weeks before their acute decline. So this, as you can imagine, does require asking some questions of people who can comment on how a person was doing 2 weeks prior to becoming acutely ill. So a couple of things I just wanted to highlight that have very recently become available to support the use of the clinical frailty scale in your day-to-day life with older adults 65 years of age and older, is there is an excellent Canadian online training module that is interactive, gives you further information, and then runs you through some scenarios and comments on the answers you provide. It actually was designed University of Ottawa by anesthesiologists. So it's got a non-geriatrics lens on the training, because what's being recognized is this is not a skill or a tool that needs to be owned by geriatrics or geriatricians. It's something that can enhance the care of everybody working with older adults. So trying to get that into the hands of more people within the health system. So that's more along the training, is this clinical frailty scale training module, free. Took me about 20 minutes, and you do get a certificate. And then there is also, and this is new since that clinical frailty scale was incorporated into the COVID-19 algorithm by the National Health Service, there's now a clinical frailty scale app that is available for iPhone and for Android. I have the iPhone link here. And it isn't a training thing. It actually is something that can help you remember what the different clinical frailty scale numbers are as you're actually trying to use it clinically, for those of you who don't have the pictures tattooed on your forearm. So now we're going to sort of run through some scenarios, and this is where I'm going to ask you to vote based on some information I'll provide. But I'll remind you again, the people that we're mainly focusing on, the line in the sand, is our people a clinical frailty scale of vulnerable, so not frail, or are people mildly frail, starting to need help with some of their household chores, starting to need help with their personal care, in which case they're moderately frail, or dependent for everything, severely frail, so they are a clinical frailty scale. So I actually see that there is a question about dementia. So I haven't been monitoring the chat dedicatedly here, but thank you for that question, because when I say for any reason, dementia can be one of the reasons that a person is starting to become dependent. So it could be that their bodies are great, but their dementia symptoms are impacting their ability to do things, then that still applies. So if a person, because of dementia symptoms, is needing help with their IADLs, but they're independent with their personal hygiene, then they're still mildly frail. What complicates it is that if somebody's got mild dementia, but physically or for mobility reasons or arthritis reasons, they're severely frail, then they'll be frailer than their dementia score. So it's the accumulation, or it's the cumulative effects of all of their different complexity that is used in the clinical frailty scale. But if their only real challenge is their dementia symptoms, then this will line up with their dementia disease severity. So thank you for asking that question. All right, so now we're going to put you guys to the test technologically and for assigning the clinical frailty scale. So our first case, all of these sort of are moderately terrifying for me. So case one, personal care home, COVID-19 positive resident is needing increasing supplemental oxygen, just needing more and more and more oxygen. So this is a 67-year-old woman who 2 weeks ago was busy, talkative, life of the social activities at the personal care home. She requires hands-on assistance for dressing and bathing and queuing to continue eating because she likes to get up and socialize. She can't clean herself adequately after a bowel movement, so she needs some hands-on assistance with toileting. She has Alzheimer's type dementia, and sorry, that should say no other comorbidities. So this is her only diagnosis, and you're preparing for an update call with her children who know that she is COVID-19 positive, but now you're talking about the fact that she's needing quite a bit more oxygen. So with the information that you have available, I'm going to ask you to vote, and I'll hover here because that'll remind you of the case. Could you please vote for how frail is she using the clinical frailty scale? I'm sorry, I don't have the picture here to remind you what the scale is. So that's Menti code 114420. So she requires hands-on assistance with dressing and bathing. She needs queuing to eat, and she can't clean herself adequately after a bowel movement. And thank you very much for those of you who participated. I'll give it another, just a few seconds. Actually, while we're doing that, I'm just gonna have a quick look at the chat and see if there was anything else fascinating that I missed. Too many options for communicating here. Great. So as you can see, there is a certain amount of judgment, and if you're a geriatrician, then you want to know the answer to a million other questions about how she's doing and how things have changed over time and what's been tried and is she on medications that are making things worse. But from the standpoint of her frailty, I'm going to give this one to the majority, but I want to take you through. Here, this is the screenshots from that clinical frailty scale app of how it would walk you through this. So it starts with sort of the most frail. So it's sort of It's a process of exclusion. So is this person terminally ill with a life expectancy less than 6 months? No. Then it would take you to question 2. Is this person completely dependent and approaching the end of their life? No, we're not expecting her to die. She has an underlying terminal diagnosis of Alzheimer's disease, but she's stable at this time. Is she completely dependent for personal care? So this is where the judgment call comes. But, she is able to feed herself. She needs some cueing to continue. And this is where the more detail comes in, that she's getting some help with bathing. She wouldn't remember that she hadn't bathed, so she needs that. And actually to follow the steps to get clean, she needs help, including with her toileting. But handed a shirt, she can put that on a good day. Some days it's upside down. Question 4, does this person need help with all outside activities and or bathing? So yes, this is where they put in that, does she need some help with her personal hygiene? Yes, she does. So she is moderately frail, and the app will sort of stop you there and say, yes, okay, she's moderately frail, she's a 6. And then it gives you a little bit more of a description that kind of allows you to say, yeah, that sounds like her, or no, that sounds too good or too dependent for her. And then how can you tell there's geriatric input in this? This is somebody who will benefit from an enhanced frailty approach, where you go looking for some of the geriatric syndromes and try to help her be the best she can be. So case number 2 is a resident of a personal care home that he doesn't have COVID-19, but the facility is in an outbreak. And unfortunately, this resident has a fall and very suspicious for having fractured his hip. He's a 90-year-old widower, recently admitted from the community after the sudden death of his wife. He had well-managed insulin-dependent diabetes in the community, and he started having hypoglycemic episodes at home after his wife's passing. He's independent, no concerns with driving. He's managing all his banking. He's benefiting from meals and medication support, entirely independent with his personal hygiene. So here I'll get you to vote again. And I'll just remind you from the information you have available, he's independent with driving, banking, benefiting from meal and medication support. And I'll just take a moment to talk amongst myself as you vote. Thank you very much for participating in the voting. So great. Again, a little bit of discussion about the nuances for this. So let's see what that app sort of guides us to here. So this one, there was enough room for the picture, the summary of the frailty scales. So in this individual, you go through the questions, and it's at the point of question 5. Does this person need help with IADLs? That the answer is yes. So important point from this case is the fact that he's 90 is neither here nor there. Now, hearing about him when he's in a Johnny shirt on the stretcher, just broke his hip, some assumptions may be made about how he was doing before. But the important thing is, in the 2 weeks prior to the hip fracture, how was he doing? That isn't saying, when his wife was alive. It's still relevant to how he's been doing since he's been in the personal care home. And what sometimes happens is that only with the change of supports does it become more obvious how frail somebody is. So he and his wife may have been a bit of a team. He may have done some of the IADLs. She did some of the IADLs. Now, he may never have been great about cooking, or maybe she always did the medications. But key to this was he he couldn't compensate enough to keep his diabetes adequately managed to live independently, for him to remain in the community. So he's mildly frail because he's independent with his personal hygiene. So one more case, and then we'll wrap up, and we'll have some questions specific to this, and then we'll open up to sort of broader conversation. So this is our last case, a resident of a PCH who is not rousable for 6 hours, is not rousable 6 hours after a fall from bed. So there's known SARS-CoV-2 in the community, not an outbreak in the personal care home. This is a 78-year-old woman with a lot of comorbidities, dementia, heart disease, history of stroke, arthritis, and for some time now, it has been fully dependent for feeding, bedbound within the last month, so well prior to the falling out of bed, has been on a modified consistency diet, significant weight loss that has accelerated over the last 3 months, and recently, so prior to the fall, has been sleeping much of the day and night. So again, I'll get you to do your voting. So fully dependent for feeding, bedbound within the last month on modified consistency diet, significant weight loss in the last 3 months, sleeping more of the time. Oh, you guys are getting the hang of this just at the time I stop polling you. Your speed of response is improving. Excellent. So again, you don't get very far into the app's questions before it kind of becomes clear how frail this resident is. Is the person completely dependent and approaching the end of life? Yes. So this, even prior to the fall out of the bed and not being able to wake her up, she was completely dependent and therefore very severely frail. Now, there is often quite a bit of sort of digging into whether or not a person is severely frail or very severely frail, as far as their ability to participate and whether or not they're stable, or if it looks like they're actually entering the end of life phase. At the point at which the sleeping is increasing, the swallowing is going down, the weight loss, consequences of being severely frail, that's when you start becoming very severely frail. So I just want to wrap up this discussion, having been through those cases, with some tips that have been published. I know this is a little hard to read, but we will be sending actually a copy of this PDF, and then you can find it at the link here, about how to use the clinical frailty scale, because people who are not doing comprehensive geriatric assessments are starting to use the clinical frailty scale, and there are some tips that will be helpful. So we've already touched on some of them. So number one, it's all about the baseline. So you're not making the comments about their frailty scale when they've just suddenly become acutely ill, or they have had a major injury or a fracture. And the reason for that is somebody who is frail or not frail can get, both groups of people can get sick. What you're wanting is, how did they differ before they got sick, as a predictor of how they're going to respond to different treatment options. Number two, you must take a proper history. So this is a challenge, you know, if especially for the older adult living alone, comes to the emergency room by themselves. So there are times when this is very challenging, but this is an objective clinical assessment tool. So you can't guess, you know, they look this frail, or I think that they probably can't because of their mobility. It's actually through getting some information about what they can do with the mobility and cognition that they have, that you assign the clinical frailty scale. I like number 3, you trust, but you verify. So there can be a number of reasons why the people providing information may be giving what they believe to be truthful and accurate information, but they may not be accurate in the information they are providing. So sometimes you need to get information from a few sources, and that may be professional. So for example, home care, because their clients, if they're receiving home care, especially for non-nursing services, then they are becoming frail. But it may be family, and there may be very different opinions. The daughter in Calgary may not have the most up-to-date information and may have very strong feelings about how independent somebody is. And likewise, the person themselves. So if there is some impaired insight or judgment, asking a person how they do their laundry may be very different compared to how their laundry is actually getting done. Number 4, I already mentioned, it's for people who are 65 and older. The approach can still inform people who are younger, but it's validated for people 65 years of age and older. Again, I mentioned that if they're terminally ill, that trumps their functional independence as far as predicting their outcomes. Having medical problems does not automatically increase the score to a clinical frailty scale of 3. So it's really about symptoms from the underlying comorbidities. You can have a long list, but unless they're causing symptoms that impact their endurance and their independence, then it doesn't actually change them to a clinical frailty scale of 3. Number 7, don't forget vulnerable. So these people are not yet frail, but are still a population to be mindful that they may be at increased risk or need some preventative interventions. Again, this isn't relevant to your work in the personal care home settings, but in an introduction to the clinical frailty scale, the vulnerable are the ones that we want to be pouring in the restorative and preventative therapy so that they don't have progression of their frailty before it's absolutely has to. As the question was already asked, number 8, dementia doesn't limit use of the clinical frailty scale. So this tip says decline in functioning in people living with dementia follows a pattern similar to frailty. So if you know the stage of the dementia, then you know their level of frailty. And the only thing I'll add to that is if their mobility or other challenges makes them frailer, then you go on the clinical frailty scale with the cumulative effects of all of their underlying challenges. And number 9, drill down into changes in function. So this is where some of the nuance, it's not just a yes, no, there is some subtlety to it. For example, in people who have never done any of the cooking or have never done any of the cleaning, asking, and don't need to, asking them whether they do those household tasks is not a fair assessment of whether or not they can do them. So that's with our case of the 19-year-old gentleman. When his wife died, he couldn't take over any, enough of his meal preparation to keep his blood sugar safe, and he couldn't take over the medications. That's a high bar. Those are skills that would be challenging for any of us to learn sort of at short notice. But there's that additional need to ask some questions around a change in function rather than just a black and white yes, no of what they do, what their lifestyle is like at home. So I'm gonna give some conclusions to this and then open it up to questions. I'll have a look at the chat specific to this talk, and then I'm going to continue the recording just for a little bit, and then I'm going to turn the recording off and open it up to broader discussions about how things are going in the personal care home setting, and we'll see how time allows for a bit of peer support here for all of us trying to help residents of personal care homes. So specific to today's topic, assessment of frailty underpins personal care home care. And in upcoming weeks, we're going to talk about some ways that things can be tailored or individualized as somebody's frailty is changing during their personal care homestay, but also during COVID-19, frailty may change the approach, or will change to the approach to talking about different care options if somebody were to become develop COVID-19. And the clinical frailty scale is a tool that allows for better assessment of frailty, and it's much better than age alone for assessing a person's frailty. But some training is required, and I would really encourage you to do that online module because it's quick and it is more articulate than I am. So I believe you can unmute yourself. I'm going to just read about any questions or chatter over in the chat box, but go ahead and ask any questions relevant to today, and then I'll flip to the next slide and we'll stop the recording when questions stop, but we've got we've got some time for conversation. So go ahead and unmute if you have any questions. So from the chat, is it clinically justified to have all long-term care residents clinical frailty scale number on the chart and review regularly once or twice a year? I feel like I planted that question right there. So, you know, I really think that that is an opportunity for us to, so in some circumstances now, home care clients may be coming to you from the personal care home with their frailty scale, and maybe as time goes on with how their frailty scale has changed over time. But yes, I think that would be extremely helpful in the personal care home, particularly coming up to that annual case review with the resident and family, because what can happen is, you know, especially for the staff that's right there, they're seeing them every day, things are changing subtly, but it can be a bit of an eye-opener, and having those check-ins, it's important for pharmacy, sort of with, you know, we made medication decisions based on how their life expectancy and their frailty when they first came in, but things changed. So I think for a lot of reasons, operationalizing clinical frailty scale periodically makes sense, and making sure that the person assigning it has some experience and training in what to ask and how to ask it, or where to get that information. So I think it would improve with communication and also care decisions that we're making to be a bit more objective in how a person is changing during their personal care home stay. For mildly frail now in personal care home, what time to become moderate can be predicted? Yeah, so exactly, and in the dementia world, we talk about sort of significant changes every 3 to 6 months, depending on people's reasons for their frailty. You know, you can maybe be thinking about different timelines for how they're changing over time, but you know, at a minimum, it's likely that every year and every 6 months it would be reasonable to reassess that, knowing that the average life expectancy of personal care home residents is about 18 months. So I'm going to put my camera here, or put those little shots of people's faces again, and just see if anybody's wildly flagging to say they have a question. Not a lot of people on. Wow, there's a ton of people. That's awesome. All right. So then I'm going to move on and stop the recording. So I think Jocelyn's going to do that. And then I'm going to open it up